My name is Jessica Gordon, and I'm a rheumatologist at Hospital for Special Surgery in New York City. I'm so grateful to be here today to give you a COVID-19 update. I'll be giving this talk today with my colleague, Robert Spiera, who will specifically be discussing COVID vaccination. I'll start off by giving an update on COVID-19 treatments and then discussing the impact on patients with rheumatic diseases. And then Dr. Spiera will follow with the discussion on vaccinations. What a year this has been. Spring 2020 was characterized by so much uncertainty about issues for people with autoimmune diseases, like what are the specific risks to them and what are the risks of the medicines they take to keep their disease in control. And although this point has come and uncertainty still exists, we have learned so much and we're at such a better place than we were just a year ago. And this year we've seen incredible accomplishments, progress, and resilience. Some of this is probably a review for this audience, but just to do some of the basics, with COVID infection, about a third of infections are asymptomatic, and there's a huge spectrum of infection severity. In one study, we saw mild disease in about 80% of patients, 14% had severe disease, and 5% had critical disease, including a 2.3 case fatality rate, and this was in China in 2020. So that case fatality rate does not account for the full burden of the pandemic, which would include excess mortality from untreated conditions because of delayed care and overburdened systems, as well as lack of care. Mortality differs across countries, so the observed case fatality rate is shown here for the 20 countries with the highest case fatality rate. This isn't mortality per country, but the rate. And there are a couple of things that can account for some of these differences that we see. So one depends on access to testing. So if there's more testing available, more patients who have mild disease or asymptomatic disease will be identified, and that will lower the case fatality ratio. Also, mortality is higher in older populations, so countries where we see a higher percentage of older people will have a higher case fatality rate. And the healthcare system is an important variable too, with mortality higher when there are hospitals with fewer resources or when they're overwhelmed, as well as other factors. So how has treatment changed in this last year? So much of COVID treatment can be done in an outpatient setting, and we've seen a huge boon to telehealth and in this context. And outpatient management winds up being appropriate for most patients. So in the outpatient setting, monoclonal antibody therapies have shown a potential benefit for patients with certain risk factors for severe disease. And these therapies can reduce rates of hospitalization and death. So there's currently emergency use authorization for 3 medicines, and currently this medication REGEN-COV is preferred to some degree because it has a greater likelihood of activity against certain variants with spike protein mutations. But who is eligible for these types of monoclonal antibodies? So not everybody, but it's for people with mild to moderate COVID, age 12 or older, within 10 days of symptom onset, who've tested positive with direct viral testing and are at high risk of progression to severe COVID. So these are the risk factors that are listed for indication: age greater than 65, immunosuppressive therapy, chronic lung disease, cardiovascular disease, chronic kidney disease. And I bolded these factors because these are applicable to a significant number of persons with systemic sclerosis. Other risk factors include obesity, diabetes, pregnancy, neurodevelopmental disorders, or dependence on medical-related technologies. So these would be the criteria. And so if if you ever found yourself in a setting where you tested positive for COVID, you want to reach out to your primary care doctor or perhaps your pulmonologist or your rheumatologist to let them know what's going on, not only so they can help you adjust your current medicines and make sure that you are doing okay and don't need additional care, but they can direct you to places where you can get these monoclonal antibody therapies, and they are a single IV treatment. You don't need to go to an ER necessarily, and you don't need to be admitted at all. In fact, they're not used in an inpatient setting. That's only in in a clinical trial. Inpatient management has changed. So for patients with more severe COVID, there are protocols for assessment. We know to prophylax for venous thromboembolism and have protocols to decide when it's necessary to use antibiotics, if there's a potential bacterial infection as well. These are all things that we struggled with a year and a half ago and are now protocolized, so it's very clear to know what to do for medical providers. For patients with who are on immunomodulatory or immunosuppressive therapies, it's really important to involve the treating rheumatologist to decide whether or not to continue these medicines. In my experience, in most settings, I'm discontinuing immunosuppressives in the context of any kind of infection, except that I'm very careful with prednisone. So these are definitely conversations that need to be had between medical teams. Dexamethasone is a steroid that helps improve outcomes in select patients, those who require oxygen. Remdesivir is an antiviral that has been developed that reduces time to recovery and reduces mortality in certain patients, and this is one that can be given in the inpatient setting. And then certain immunosuppressive medicines like tocilizumab and baricitinib are used to help suppress the hyperinflammation that can be seen in severe COVID. So those can also be used in select patients. So there are a lot of treatments that are available and that are used regularly that are used now that we didn't know about necessarily a year and a half ago. I'm going to take a moment to talk about telemedicine. It's not really directly related to what we're talking about, but this has been such a change over this last year that the pandemic has brought. And this isn't a substitute for in-person care. And I wanted to make these points while I had your attention. I love telemedicine, and then in the same moment, sometimes I find it frustrating because it does make certain aspects of medicine challenging, and then it makes certain aspects so easy. So again, not a substitute for in-person care, and then just a few pieces of advice. Be sure when you have your telemedicine appointment to log in early, because there's always something that goes wrong with logging in or something that you have to sign. Be sure your doc has whatever information you want them to review. Don't assume that it'll sort of be in the system. Make sure if there's an important document like your pulmonary function test report or your echo report that they have that beforehand. And if there's something they need to see, like something on your skin, be sure to take a photograph and send that. Do the visit in a quiet place with reliable Wi-Fi, like not in the car on the way to vacation with the whole family in the car. And then just also be aware that laws are changing and are going to vary state by state. So especially if you're seeing a physician in another state than where you are, it's important to pay attention to these rules because they will be changing. So now let's get to discussing how do people with scleroderma and other rheumatic diseases do when they get a COVID infection. So this depends on a lot of factors. How severe is their immune condition? Is it well controlled? Which organs are involved? Do they have other medical problems? We use the term comorbidities. So do they have obesity and diabetes and cardiovascular disease? What treatments are they on? Age and sex. So a lot of different variables. And so I want to share with you a couple of papers that come out of the COVID-19 Global Rheumatology Alliance group. And this is their website if you want to check it out. And this is an international registry where rheumatologists are able to share cases of different patients with rheumatic disease who've had COVID infections. And they have a couple of important papers. I'm going to share with you the info from those. It's really been super helpful. But when we're interpreting those papers together, I want you to know when you look at those numbers that these patients that are in this registry, there's a bias to reporting of more severe cases. So I wouldn't use it to look at a description in general of how folks with rheumatic diseases do if they get COVID, because a given rheumatologist isn't going to go through the process of reporting necessarily unless it was a more severe case. So, but we do get a lot of really important information from them. So one of them, this paper here, looks at the association with baseline use of biologic or targeted synthetic DMARD, so the medicines that we use to modify disease with COVID severity. And this paper specifically was looking at people with rheumatoid arthritis, and they found that those who were treated with rituximab or JAK inhibitors, like tofacitinib is one of those, had worse COVID-19 severity than those who were on TNF inhibitors. They didn't see any association with COVID severity with abatacept or IL-6 inhibitors like tocilizumab and COVID severity. So in this paper, they looked at about 2,800 patients with RA, and they saw 21% were hospitalized and 5% died. And the odds of one of those severe outcomes were about 4 times higher if you were on rituximab or a JAK inhibitor. So this is important for us to think about and know, and we are going to think a little bit more about it as we learn more. So another paper from this group looked at factors associated with death from COVID in a broader group of patients with rheumatic disease, not just RA. And this one had about 3,700 patients, and they saw several independent factors associated with death from COVID, and that included age. That was very important. So age between 66 or 75 had a 3 times higher risk than those who were less than 65, and then that was even higher in those over 75. Male sex had a slight increased risk, hypertension with cardiovascular disease as well, chronic lung disease, treatment with prednisone greater than 10 milligrams a day also was a risk for poor outcome. But also having moderate or high disease activity versus remission or low disease activity was a risk for COVID-related poor outcome. So that means that we should really think about making sure we have disease activity in check. They looked at medications specifically and saw a similar risk for rituximab. Sulfasalazine in this study strangely had an increased risk. I'll say strangely because it's not really thought of as a significant immunosuppressant. Other medications that might sound familiar, like azathioprine or Imuran, cyclophosphamide, cyclosporin, or mycophenolate or tacrolimus also had some increased risk when they were looked at. But also, being on no medicines had an increased risk. So increased odds of death in those patients seen who are not receiving any DMARD at all. And that's something for us to think about. Are those patients that didn't have good control of their disease? So it's really important for us to think about this and interpret it, but not be too rash to change our treatments ourselves. It's just important for us to think. So this is another study that took a look at how the pandemic affected patients with rheumatic disease, but this study took place in Sweden, where they have lots of registries, and they were able to compare annual all-cause mortality and risk of hospitalization and death due to COVID during that early pandemic area in patients with RA and inflammatory joint disease and compare it to the general population. And they do see a difference in all-cause mortality with higher mortality in patients with RA and inflammatory disease during the initial part of the pandemic, although in relative terms it was similar to some of the degree of increased risk seen in those groups compared to general population. And it turned out that that risk was largely explained by some of the comorbidities and socioeconomic factors that also track along with having these rheumatic diseases. So they noted in this study too that there was some signal for increased risk from rituximab and JAK inhibitors based on a very limited number of events. But let's talk about systemic sclerosis specifically. So this is a study that was a nationwide survey in Italy during the lockdown in March and April 2020 with 1,600 patients with systemic sclerosis, and it was a telephone survey. And at that time, there was definite COVID reported in 1% of the patients surveyed, and highly suspected COVID in 3% of patients. And this was a bit higher than what the general prevalence was in Italy at the time, but it could have been an over and underestimate because these telephone surveys aren't completely accurate. But they did note that most patients had mild to moderate manifestations, but 15% of the symptomatic patients did require hospitalization, and sadly 4 of the 61 patients who were symptomatic did pass away. 2 of those were gentlemen in their 80s. One was a woman in her 60s with significant interstitial lung disease, and one was a younger woman in her 40s who had rapidly progressive systemic sclerosis with cardiopulmonary involvement. They were able to see that definite COVID was more frequent in those who had interstitial lung disease, and they didn't see associations with ongoing treatment in this study. Now, what other kinds of effects have we seen in patients with systemic sclerosis that are reported in our literature? So another questionnaire study looking at patients from India looked at about 428 patients, and they noted that 92% of patients missed a scheduled outpatient visit with their doctor, 22% skipped prescription drugs, 22% had a family member lose a job, and 46% reported financial difficulty. 10% of the patients in this group had COVID, but the infection was confirmed in only 4, and they did see worsening of scleroderma in about 40% of their patients during this time. So really important for us to make sure we're having our continued follow-up despite the challenges that the pandemic is bringing. Another study looked at patients in Iran and described their outcomes, and also didn't see any mortality. And also the mental health impact of COVID has been studied as well. And so this first study I'm sharing with you is in the general population, and it's actually a systematic review looking at multiple studies that looked at the psychologic distress of COVID-19 in different countries. And so you'll see the rates that I'm showing in the slide show a lot of variability, but there were relatively high rates of anxiety, depression, both of those up to about 50%, post-traumatic stress disorder seen in up to 50%, psychologic distress and stress in general were seen in people too. And risk factors associated with distress included female, gender, younger age group, pre-existing chronic illness or psychiatric illness, unemployment, being a student, and frequent exposure to social media or news concerning COVID-19. So I don't think this is surprising to anyone, but I do just want to show some of what's reported in the literature. So what about mental health in patients with rheumatic diseases? So, one study investigated the impact of the lockdown measures on emotional well being in patients with fibromyalgia and rheumatoid arthritis, as well as healthy controls using a telemedicine approach. And they saw high levels of anxiety with 37% in fibromyalgia and 14% in RA and about 12% in healthy controls. High levels of depression with about 50% in fibromyalgia, 17% in RA, and 15% of healthy controls. So healthy controls featured actually the highest stress scores, followed by fibromyalgia and then rheumatoid arthritis. And the RA patients showed higher resiliency scores. And lockdown significantly affected the emotional well-being of patients who are suffering from rheumatic diseases. So another group that I'm a huge fan of and I'm a part of is the SPIN group, or the Scleroderma Patient-Centered Intervention Network. And they have also looked at mental health impact, specifically how it affects patients with scleroderma. So in one of their studies, they investigated the fear of consequences of COVID-19 among patients with systemic sclerosis, and they compared pre-COVID data to data collected during their baseline assessment and initial entrance into the SPIN cohort. And they saw that fears due to COVID were a little bit higher in patients in the UK than France, somewhat higher in Canadians, with the US not statistically different than France, and that there were higher levels of fear related to patient-reported breathing issues, lower financial resources, as well as higher pre-pandemic anxiety scores. So this group went on to study an intervention, which was a support and educational program related to anxiety symptoms during the pandemic. And it was a randomized controlled trial. And they were looking at effect of the intervention on anxiety right after the intervention, as well as 6 weeks later. And they found that anxiety and depression symptoms were lower at that 6 week later endpoint, but not right after the intervention, interestingly. So, it's possible that it takes a little bit of time to incorporate new skills in a way that affected mental health. But I think this was an important study. So to conclude my section of the COVID update, what I hope to have done was to summarize the updates in our knowledge of COVID-19 treatment and how it affects patients with rheumatic diseases, especially systemic sclerosis. Risk factors for issues related to COVID include age and sex, as well as disease activity and medication. And although certain medications may increase the risk of complications, having disease flare or uncontrolled autoimmune disease leads to complications too. So it's really important to look on a case-by-case basis to decide what's the best thing to do going forward. And this is going to entail close communication and frequent follow-up with your rheumatologist for these medical decisions. So with that, I'm going to thank you, and I'm going to pass the presentation on to Dr. Spiera, who will talk about COVID vaccination.
Hi, I'm Robert Spiera, also from Hospital for Special Surgery, and I work closely with Dr. Gordon, as you all know. In this section of the talk, we'll focus on COVID-19 vaccine and scleroderma. This is one of those talks that I hope will become less relevant to the scleroderma community and to the medical community more broadly over time as the pandemic hopefully leaves us. We know that the toll of COVID has been tremendous. Worldwide, there have been nearly 200 million cases and nearly 4 million deaths already documented. And undoubtedly, by the time you watch this, those numbers will be higher. In the US alone, nearly 35 million cases and over 600,000 deaths to date. But those are just the direct costs. There have also been enormous indirect costs, including poverty, starvation, and of course the psychological impact of having this pandemic with us and the isolation associated with it. A number of strategies have been used to mitigate the damage of COVID. And from a public health standpoint, and also from an individual standpoint, prevention is paramount. That included activities such as social distancing, hygiene, washing, wearing masks, but also vaccines, which will be the focus of this talk. But I don't want to ignore the fact that therapeutics may very well play a bigger and bigger role in COVID if necessary. There are antivirals being developed. There has been some interest in convalescent plasma to treat patients with severe COVID, although that excitement has waned to some extent. There have been monoclonal antibody therapies targeting components of the virus, which have been shown to be helpful in some patients with COVID. We've also repurposed some of our anti-rheumatic drugs, utilizing their anti-inflammatory or anti-cytokine properties to help mitigate the damage from that robust inflammatory response to the viral infection. Vaccines, however, seem to be one of our greatest weapons in fighting this pandemic, and I think the reality of what life looks like in America right now compared to 6 months ago really bears that out. And there have been 3 types of coronavirus vaccines mostly looked at least in this country. The first is a protein-based strategy. That is not yet approved, but Novavax has a strategy where they're going to introduce the spike protein itself, which is purified and then injected with something called an adjuvant, which boosts the immune response to help to try to induce these protective antibodies by the immune system recognizing that protein and reacting and producing these protective antibodies. There's adenovirus vaccines. The Johnson & Johnson vaccine is such a vaccine where the spike protein itself has its gene purified and introduced into the genomic code of the adenovirus. This virus is then introduced to the patient, and it is not a virus that's going to be dangerous to the patient. And the virus's machinery expresses the protein, and the body's immune response then recognizes that protein as foreign and creates these antibodies, which we think are protective. And finally, there are the mRNA vaccines, in which mRNA that codes for that spike protein, again, we're all utilizing the spike protein as the target of our immune response, but that is introduced and is incorporated into the muscle cell of the injected recipient, and the body sees the protein and has an immune reaction to that protein, which includes making antibodies that hopefully are protective against the infection. And as of the time that I'm giving this talk, there have been 3 vaccines which have received emergency use authorization from the FDA in this country. There's the Pfizer vaccine, which is an mRNA vaccine. That's 2 doses separated by 3 weeks and approved for individuals over the age of 12. The Moderna vaccine, which is also an mRNA vaccine, also 2 doses, but separated by 4 weeks, and as of this time, approved for people over the age of 18. And then the Johnson & Johnson vaccine, which is an adenovirus vector vaccine, which is a single dose and approved for people over the age of 18. All of these vaccines are safe and effective, and most importantly, they reduce severe disease, hospitalizations, and dramatically reduce the risk of death. I should mention that in other countries, other vaccines have been approved, including the AstraZeneca vaccine. There's a vaccine that was produced in Russia, which looks promising, and other vaccines worldwide, which have been used in other countries using different ones of these. I want to focus for a second on the mRNA vaccines because this is a relatively new technology for in-human use, but there has been a long-standing development program, including mammalian models. I want to clarify that when getting this vaccine, you are not incorporating the genetic material into the recipient's DNA, but rather that mRNA serves as a code which is interpreted by the body's machinery to code for a protein, in this case that spike protein, to which the body will have an immune response. The mRNA itself that's introduced has a very limited half-life in the vaccinated individual, and it produces a robust response to the targeted protein, and that's why it works. Adenovirus vector vaccines, however, such as the Johnson & Johnson vaccine, utilize a well-established technology which has been used in humans and other diseases. These are not replicating viruses, so the adenovirus vector will not make the host, the recipient of the vaccine, sick, and so it can be used in immunocompromised individuals, which is particularly important to our patients with rheumatic diseases in general and scleroderma specifically. When the vaccines began to be available, patients often asked me, which COVID vaccine should I choose? At that time, there was a shortage of vaccine, so my answer was generally take the one to which you have access as soon as possible. Now, vaccines are more widespread and available, so this is worth some thought. I should mention that all three of the vaccines available in the US are highly effective, particularly with regard to preventing hospitalization and death. The two mRNA vaccines, Pfizer and Moderna, have slightly better efficacy data in their clinical trials, but trial differences make comparing results of different trials very difficult. That's a methodologic issue that every clinical investigator recognizes. And also recall the adenovirus vector vaccine technology has a longer track record in human use. Some patients are very skittish about getting vaccines in general. They just don't like the injection. So remember that the J&J vaccine is just a single vaccine administration as of now. And there may be unique concerns in individual patients that may be relevant, and I'll get to some of those later. What are the COVID vaccine questions in patients with scleroderma that are really more unique to scleroderma itself? Well, number one, have these vaccines been specifically studied in others with my underlying condition? What will be the impact of the vaccine on the status of my disease? What will be the impact of my underlying condition on the safety and efficacy of the vaccine? It's conceivable that in some conditions, the vaccine may be less safe or less efficacious. So how does that relate to scleroderma? I'll try to answer some of these questions. What will be the impact of my medications on the safety and efficacy of the vaccine? And should I adjust my medications when the vaccine is administered? In general, we should think about how rigorously COVID vaccines have been studied in patients with autoimmune diseases. And this was a much more complicated and difficult discussion with our patients in January than it is now when we have more real-world experience. We acknowledge that patients with autoimmune diseases were not well represented in the initial clinical trials that led to the approval of these vaccines. Nevertheless, there is a strong recommendation from the American College of Rheumatology, the Scleroderma Foundation Medical Advisory Board, most of us as physicians, and other patient groups to vaccinate patients with these vaccines. And there is a long track record of safety and efficacy in general of other vaccines in patients with autoimmune diseases. And by the time I'm giving this talk, there has been this growing real-world experience in patients with rheumatic diseases, including scleroderma, suggesting excellent safety and likely comparable efficacy. And these are being more rigorously studied as we observe people over time. But patients and physicians have to recognize, in the absence of hard disease-specific data, we still have to make decisions based on scientific rationale and extrapolation from prior experience. And remember, COVID can be a very bad disease, of course. The first question is, what will be the impact of the vaccine on my underlying disease? We recognize that nonspecific inflammatory reactions to the vaccine can and do occur, not necessarily in people with rheumatic diseases, but in general. Things like fevers, joint pain, muscle aches, flu-like syndromes. But these do not necessarily seem to represent disease flares in patients with rheumatic diseases. And at least to date, there have not been strong suggestions of disease-specific flares identified in patients with rheumatic diseases, including scleroderma, who have been vaccinated. Also, just learning from our experience with other vaccines, those have historically been recommended and broadly used in patients with autoimmune rheumatologic conditions, generally without recognition of disease flares. And this does continue to be an area of active investigation by a number of investigators around the world. We do at this point have some research to help us feel more encouraged that these vaccines do not trigger disease-specific flares in patients with rheumatic diseases. And I'm sorry these are all very small and do not project well, but I'll walk you through it a little bit. On the left panel is a study done in patients with rheumatic diseases, including rheumatoid arthritis, psoriatic arthritis, and ankylosing spondylitis. These three are all inflammatory arthritides. And then lupus, which may be a little bit more similar to scleroderma itself. And they looked at patients and conducted these disease outcome measures before and after receiving the vaccine. And what they recognized is the orange bars, which indicate that disease has been stable, was the most common occurrence. The blue bars actually represent people being measured as having improvement following the vaccine, was similar across groups. And worsening did occur, but wasn't really more common than improvement. So remember, people with these autoimmune diseases sometimes have fluctuations in their disease activity by chance alone. This study was incredibly encouraging, telling us most people remain stable. And it doesn't look like more people get worse after the vaccine than people getting better after the vaccine with regard to their underlying autoimmune disease. In this table on the right, this is a different study, also published recently. They just looked at adverse effects, complaints after a vaccine in patients who did not have underlying autoimmune diseases, what's called healthy controls, versus patients with rheumatic diseases. And the most common side effects of vaccines are common. Pain at the injection site, redness at the injection site, maybe a little bit of swelling or fatigue or headaches, and even joint pain and muscle pain, but these look comparable whether you had an underlying rheumatic disease or not. So in other words, somebody with, let's say, lupus who gets achy or in a low-grade fever after a vaccine might think that represents a flare of their disease, but at least in this study, it suggested that those occurrences happen as frequently in people without underlying lupus in response to the vaccine. There are some safety considerations that I think we should mention specifically that have emerged more recently with regard to the vaccines that are a little bit more specific to the scleroderma audience. And here the numbers are very small, but I just wanted to address it because I think there will be questions about it. Number one, myocarditis and pericarditis. We heard a little bit about that initially coming out of some of the Israel reports, but also now from the CDC. Myocarditis is a condition where the heart muscle itself can become inflamed. Pericarditis, where the sac in which the heart sits, there's this tissue around the heart that can become inflamed. And these have been described after the vaccine in some recipients. And it has not specifically necessarily been described in people with autoimmune diseases, but it's been described. It's very infrequent, and it's mostly occurred in males between the age of 12 and 29. And most of those had received the mRNA vaccines. The general expectation is complete resolution of the problem, but this remains a safety concern. No evidence exists at this time that is more common in patients with a prior history of myocarditis or pericarditis, but there's very little limited information on those patients. And I think rationally, if somebody does have ongoing myocarditis, which does occur in patients with scleroderma, as does pericarditis, if there's evidence of that going on prior to vaccination, that has to be a very careful discussion with the treating physicians. And I would advocate for close monitoring after vaccination in such individuals, especially if they're in this age group where there seems to be a somewhat higher risk. The second thing that received a lot of press was these episodes of thrombosis or blood clots and low platelets, thrombocytopenia, which have been described in some patients, particularly after receiving the J&J vaccine. This was very, very rare. It generally occurred in females, and it has not been described, to my knowledge, in patients with scleroderma to date. Well, what about the use of our underlying anti-rheumatic medications around the timing of COVID vaccine administration? This is maybe the most frequent question I get asked recently as more and more people are getting vaccinated. So I will point out that guidelines are being developed, but they are really not evidence-based. We haven't tried different regimens of adjusting medications or not adjusting medications, nor do we have very robust evidence of the impact of medications on the vaccines. But I'll give you a little bit of what we do know. And these considerations are mostly related to the potential impact of the medications on vaccine efficacy, not safety. We haven't seen or thought about a particular safety concern that the use of anti-rheumatic medications might impart on a patient taking those medications who is going to be vaccinated. The guidelines that are out there can and likely will evolve as more experiential evidence grows and as more data is identified. And ultimately, decisions regarding specific medication changes must be individualized and discussed with the treating physician. That being said, the American College of Rheumatology did develop COVID-19 vaccine clinical guidance for patients taking anti-rheumatic medications and for patients with rheumatic disease in general, and they already have a second iteration of this, which should be available shortly. In their guidelines, I'll just point out, this is looking at different medications that might be used, and there's no evidence, so they just describe the level of agreement of the physicians who were part of this task force who helped develop these guidance as either strong, moderate, or weak. And for the most part, it was felt that methotrexate dose, there was some agreement that people should hold the methotrexate for one dose after each vaccine dose, particularly in those with well-controlled disease. Again, this is not evidence-based. More importantly, there was some agreement and moderate agreement that other drugs that are relevant to scleroderma mostly should not be adjusted, most importantly, including mycophenolate. There are some people who are treated with abatacept who have scleroderma. That's a drug where there were some concerns how it might affect vaccine efficacy, and there was a suggestion to alter the dose of that medication. And the one that is emerging as potentially the biggest problem in terms of being able to demonstrate vaccine responsiveness is rituximab, which is also being used more and more in patients with systemic sclerosis. And I'll talk about that a little bit more. But I'd like to put this in a context. Number one, right now, at this point in time, responsiveness is something we're measuring mostly with the anti-SARS-CoV-2 spike antibodies. Those are measurable. The spike protein is what the antibodies are directed against, and that's the protein that's the component of the vaccine. And we are using that as a surrogate to indicate vaccine responsiveness, but it does not capture other components of the immune response, such as T-cell immunity and other features of the immune response. And remember, the goal of vaccination is not just to create an antibody, but it's to protect from infection and severe disease. Antibodies may be a surrogate for that. We haven't proven that yet, but it's only part of the protection. And indeed, the CDC and the American College of Rheumatology actually recommend not measuring the antibody response. Ultimately, the important data will be demonstrating less infection and less severe disease, but those studies will not be imminently available. And I'd like to focus on what little data there is on the anti-rheumatic medications that I think are most relevant to patients with scleroderma, being methotrexate, mycophenolate, and rituximab, which many patients with scleroderma are treated with. Now, there is some corticosteroid use, prednisone use, or methylprednisolone use, and some abatacept use. I won't focus on that as much because when we use steroids in patients with scleroderma, generally they're at very low doses. This was a study from our group at HSS where we looked at anti-rheumatic medication use and the likelihood of having a serologic response to the COVID vaccine, being able to measure antibodies. And what I'd like to point out is that the drug that showed the biggest signal for preventing an antibody response or being associated with not having an antibody response was rituximab. So out of our 30 patients treated with rituximab, 20 of them did not develop antibodies. We also found that a patient treated with belimumab, which like rituximab is an anti-B cell strategy, did not develop a vaccine response. That was half of the patients treated with belimumab. We did not find that other anti-rheumatic medications, including methotrexate and mycophenolate, was associated with a significant lower likelihood of developing a vaccine response. On this panel, we looked at how you might use rituximab in these patients, and we recognized that, number one, those with a negative antibody response were much closer to the time of their most recent rituximab infusion. The median number of days was 98 days, whereas those who did have a good response were much further out. So this is time from rituximab infusion to measuring the antibodies. This slide represents only a few patients, but it was an interesting observation that when patients remained depleted of their B cells, which we know is an effect of rituximab and an expected effect, and they got vaccinated, they were very unlikely to develop an immune response as measured by antibodies, whereas patients who did have antibody responses had mostly reconstituted their B cells, and that's something we can measure, and this might inform our decisions about how to time rituximab doses relative to vaccine or vaccine relative to rituximab doses. These are two other studies. This was a study looking at patients with rheumatic diseases and broke it down by different therapies. And I'd like to point out in this study, of the patients treated with mycophenolate, only 3 out of 11 developed positive antibodies, whereas 8 out of 11 did not. And that was statistically significant. Similarly, out of 6 patients treated with rituximab, 4 did not develop antibodies, 2 did develop antibodies, really very comparable to the numbers we saw. And in this experience, methotrexate was not really associated with a lower likelihood of an antibody response, but it is only about 50% of patients who developed antibodies who were being treated with methotrexate, so maybe there was something there. This panel I won't go through was another study out of Hopkins where they looked at patients who did not have a serologic response to the vaccine following its administration, and this doesn't project, but the use of rituximab and mycophenolate is overrepresented in that group as opposed to their patients who did have a response. Similarly, some have raised concerns regarding methotrexate. Again, I apologize, this doesn't progress well, but in this study by Bugatti's group, they recognized that methotrexate-treated patients were often, but not usually, non-responsive. It was a minority who were non-responsive, whereas in this study from the NYU group, they recognized that although most of the patients on methotrexate had an adequate response, about 25% of them didn't, and in those that did, the levels of antibodies were lower. So we should think about whether we should incorporate strategies to increase the likelihood of an antibody response. For mycophenolate, some have advocated holding a dose around the vaccine. This is not the recommendation of the ACR, and the duration and timing of that is uncertain. For methotrexate, some, such as the ACR guidelines, have advocated holding a dose 1 week after each vaccination. And for rituximab, we try, when possible, to wait at least 6 months from the last Rituxan infusion before vaccinating, and then hold off on the next rituximab infusion until 2 to 4 weeks after the second vaccine dose, or after the one vaccine dose if it's J&J. And our group is starting to look at B-cell reconstitution prior to vaccinating or revaccinating. Some other considerations in patients who have been unresponsive by antibody testing are outlined on this slide. One would be considering administration of an additional vaccine dose, and indeed this has been described recently in 2 studies in transplant patients who did not have antibodies after their first series of vaccines, where their antibody presence increased from 0% to 33% in one study or 44% in another study with an additional dose. But also, and most importantly, remember that the antibody testing only captures one component of the immune response. Recently, the FDA authorized an emergency use authorization for a T-cell assay. It's a different arm of the immune system to look for whether there has been evidence of prior COVID infection, and that assay may be relevant to show immunity to COVID after vaccination. So that's something we're exploring actively. I will say that there was a report recently by Benelli's group showing in patients with rituximab, a small number, I think it was 2 of them, who did not have a response to the vaccine as measured by antibodies, they did have evidence of good T-cell responsiveness. There are some other considerations I'd like to mention relating to the COVID vaccine, much of which we don't have evidence for yet. One is, what is the timing of protection after the vaccine? We've all heard about boosters. When will that be required? Will it be required? We simply don't know yet, and this may be something that may be different in different patients, including patients who don't demonstrate a serologic response to the vaccine in the first place. What will be the relevance of variants? Most recently, we've heard a lot about the Delta variant, but encouragingly, it looks like the currently approved vaccines do seem to be effective, particularly with regard to preventing severe disease. Number 3, the guidelines related to social distancing and wearing masks continue to evolve and will continue to be revisited as more data emerge. Clearly, you're at dramatically lower risk after receiving the vaccine, and that should help inform individual decisions. And finally, remember that vaccination does seem to reduce the risk of transmitting the virus to others, but that protection is likely imperfect. And finally, and this is an important take-home message, don't underestimate the impact psychosocially of isolation. This has been one of the real major burdens and costs of this pandemic. On behalf of my colleagues, including Dr. Gordon, but as well as our larger group, I'd really like to thank the Scleroderma Foundation for this program and the opportunity to speak to you.